Hello students, welcome to the new session of physiology, that is the functions of the renal system or the functions of the kidney and the physiological anatomy of the renal system. Now, what are the functions of the kidneys in our body? As you might be well aware, or is the most common function, that is excretion. Excretion of what? Excretion of metabolic waste products, excretion of foreign chemicals, excretion of drugs, excretion of hormone metabolites. So all these products, they are being excreted and homeostasis is being maintained. Next important functions of the kidney or the renal system is to maintain body fluid homeostasis. Now what is the meaning of body fluid homeostasis? The amount of the body fluid is being maintained constant. As we have seen in our previous lectures, the kidneys can regulate the amount of urine output, and depending upon that, the amount of body fluid that is being regulated. Next important function is to maintain the electrolyte homeostasis or the electrolyte balance. So kidneys can exactly regulate the amount of electrolytes which should be excreted by the urine, and by that way the electrolyte concentration in the blood or the plasma is being constantly monitored or is being regulated by the kidney. Next important function of the kidney is to regulate blood pressure. Now, how does the kidneys regulate the blood pressure? Can you recall the long-term regulation of the blood pressure in the cardiovascular system? So, how does the kidneys will regulate the blood pressure for longer time? Suppose the blood pressure has increased. Now, what the kidneys will do? Now, the amount of the blood is 5 liters. So, if the kidneys decrease the amount of the blood slightly, let's say 4.5 liters, so what will happen? The vasculature, the area or the volume of the vasculature is same. The amount of the body fluid, that is the blood, has decreased. So, what will happen to the pressure? The pressure will decrease. So, even with the slight change in the blood volume, kidneys can maintain the blood pressure for a very long time. So, this is how the kidneys can maintain the blood pressure. Remember the renin-angiotensin system, which is very important to maintain the blood pressure. Angiotensin can cause vasoconstriction, and by that way it can increase the blood pressure. Next important function of the kidney is to maintain the acid-base homeostasis. The pH of the plasma, that is 7.4. This is a very important factor which the body has to maintain, the pH within normal range. Otherwise, it's going to disturb the number of the reactions. So the pH is maintained by the kidney. How does it maintain? Number of the acids they are being produced: sulfuric acid, phosphoric acid. Volatile acids, which are the one which can be excreted through the lungs through CO2, which will be converted into CO2 and that can be excreted. But the kidneys will have to take care of the non-volatile acids, which cannot be dealt by the lungs. So the non-volatile acids such as sulfuric acid, phosphoric acid, these are being excreted by the kidneys. Kidneys can excrete large amount of H+ ions. At the same time, the kidneys can even excrete or it can even generate new bicarbonate ions. If there is alkalosis, kidneys will excrete bicarbonate ions. If there is acidosis, the kidneys will generate new bicarbonate ions and that will be incorporated within the blood. So in this way, by that way, the kidneys can maintain the acid-base homeostasis or it can maintain the normal blood pH. Then one has to remember, if the person with the kidney failure or will suffer from anemia also. Now how can you relate this? Recall from your knowledge of hematology that an important factor which is called as erythropoietin is being secreted by the kidney, synthesized and secreted by the kidney in response to hypoxia. So if the person with the kidney failure, they will have to give supplements for the erythropoietin so that the anemia should not occur. Next, a person of kidney failure will also have the disturbance of calcium metabolism. The person can have osteoporosis. Can you tell me why? That is common questions which can be asked. So you have to remember that kidneys will synthesize 1,25-dihydroxy vitamin D3. It will incorporate the hydroxy and it will synthesize diazepam. This is very important for the calcium metabolism or calcium absorption. So in this way, the kidneys are required for the vitamin D metabolism and in that way for the calcium homeostasis. And it was seen that in a long case of starvation or in a fasting case, the kidneys can synthesize some amino acids as well as glucose. Kidneys can cause some gluconeogenesis, but that is in some of the exceptional cases, right? So these are the various functions of the kidney. Now we will go to the physiological anatomy of the kidneys. Kidneys, as you know, they are called as bean shape and bean are called as kidney shape. So this is the common structure of the kidney, which we will call it as a bean shape. This is called as the hilum or the induction which is there. These kidneys, they lie on the posterior wall of the abdomen. You have to remember, from surgical point of view, they are the extraperitoneal one. Each kidney weighs about 150 grams, and the size of the kidney is, we can call it as a clenched fist, approximate size, we can get it from that. It has got the hilum from the medial side, and one has to recall what are the structure which passes through this hilum. The most important is the ureters will exit from this hilum. Ultimately, they will empty into the bladder. Renal artery will enter through the hilum. Renal vein will exit. The lymphatics will also exit from the hilum. Now, going to the detailed structure of the kidney again. Remember, the kidney has got a tough capsule surrounding it so that it will prevent the damage, or if the kidney has to enlarge, that will prevent the enlargement of the kidney because of the tough capsules. The ureters ultimately will end into the bladder, and from the bladder the urethra will start, and ultimately the urine output will be there from the urethra, external urethra opening. One has to remember that the urethra, the length of the urethra is short in female and long in male. Short urethra will create some of the problems, common problems such as the urinary tract infections, which will be much more common in the female because of the short urethra related to that. Going now to the histological structure of the kidney. Now, if you dissect the kidney like this horizontal section, what you will see that the kidneys can be divided into the outer rim, which will be called as the cortex, and the inner part that will be called as the medulla. So this is the cortex and this is the medulla. What lies in the medulla? About 8 to 10 such renal pyramids. These are called as renal pyramids that will be there in the medulla. The base of the renal pyramid is at the junction of the cortex and medulla, whereas the apex, which is called as the papilla, which will be there towards the hilum. Now this papilla, ultimately it will end into the minor calyx. Minor calyx will end into the major calyx, and the major calyx will ultimately end into the renal pelvis. So this renal pelvis, and from the renal pelvis, what is going to start is the ureter. Remember, whenever some urine is ultimately get collected into the renal pelvis has got the musculature, smooth muscles, and whenever there is a stretching of this smooth muscle, peristalsis that can be generated, and with the help of the peristalsis the urine can be drained and ultimately it will go into the bladder, right? Now we will see the structure of nephron. This is a typical nephron which I have drawn. This is the afferent arteriole. We will see that is the blood supply of the nephron. This is the afferent arteriole which will divide into the capillaries, which will be called as glomerular capillaries. And this is the glomerulus along with the glomerular capillaries, and this is the Bowman's capsule. So whatever the capillaries, that is the blood will be there in the glomerular capillaries, it will be filtered into the Bowman's capsule, and here the Bowman's space. From here the filtrate, now we will call this as a filtrate. The filtrate will go to the proximal convoluted tubule. Can you see the convolutions here? So this will be called as proximal convoluted tubule, or in short we can call it as PCT. Now next the filtrate will pass to this is called as loop of Henle. This is called as loop of Henle. This is its descending limb and this is its ascending limb. The descending limb is generally called as thin descending limb, whereas the ascending limb has got two parts, the thin ascending limb and the thick ascending limb. Now why it is called as thick ascending limb? Because the cells here, they will be columnar and which will have number of functions, will be see. Whereas the cells in the thin ascending limb, that will be flat one, right? So this is called as thick ascending limb. And now you have to carefully look at this structure. The part of the ascending limb, and when it starts, this is the part which is called as the distal convoluted tubule. So this is the proximal convoluted tubule, this is the distal convoluted tubule. The initial part of the distal convoluted tubule will pass between afferent and this is called as the efferent arteriole. Aff means what? Towards. If means away. So this is called as afferent arteriole, this is the efferent arteriole, right? So the part of the DCT or distal convoluted tubule will pass in between afferent and the efferent arteriole. This structure together, this is called as juxtaglomerular apparatus. This total structure together, that is the afferent arteriole, part of the afferent arteriole, part of the efferent arteriole and part of the DCT which is passing in between them, this is called as juxtaglomerular apparatus. Juxta means what? Lying. Glomerulus near. Lying near to the, that is the glomerulus. So that is called as juxtaglomerular apparatus. And from this DCT, what we have got is the collecting tubule. So this is the cortical part of the collecting tubule, medullary part of the collecting tubule, and ultimately we will have the collecting duct which will go into the minor calyx, major calyx, and ultimately the renal pelvis and the ureter, the kidney, there the filtrate will pass from that. So this is the passage of the filtrate through which it has to pass. How many nephrons each kidney have? Each kidney have about 0.8 to 1 million nephrons. One has to remember, kidneys cannot regenerate nephrons. So once the nephrons they are being lost, that is permanently they are lost. But one has to appreciate the functional capacity of the other nephrons also. Because the person will not suffer from major electrolyte imbalance or any other pH changes, major changes, up till 75 to 80% of the nephrons they are being lost. So how the function of the lost nephrons is being compensated by the healthy nephrons? This is called as adaptation. So what will happen if some nephrons they are being lost? The other nephrons will adapt and they will do the function of the lost nephrons. Normally the number of the nephrons decreases steadily after 40 years. That is 10% every 10 years. This is by the rule. We have seen about the parts of the nephrons. Now, where does actually this nephrons lies in the kidney? For that again we will have to look for the transverse section. Now again I have drawn the structure of the kidney and I have drawn the nephron, where exactly it is located. This is glomerulus, this is PCT, this is loop of Henle, this is DCT, then this is the collecting tubule and ultimately the collecting duct. This is another nephron which is there. Now as you can see in both of these things, that glomerulus, PCT and DCT, they will be mainly lying in the cortex. What lies in the medulla? In the medulla there is loop of Henle and the collecting duct. So as you can see in this picture, we can call, depending upon the location in the kidney, we can have two types of nephron. These are called as one which are lying near to medulla. Juxta means what? Lying near. So the one which are lying near to medulla, these are called as juxtamedullary nephron. But in contrast to that, the major part of this nephron which is lying in the cortex. So this will be called as cortical nephrons. So which are the two types of nephrons? Juxtamedullary nephrons and the cortical nephrons. Now, what are the other differences? What you see? You can see that is the loop of Henle. Loop of Henle is longer one and which lies in the medulla in case of juxtamedullary nephron. Whereas the loop of Henle is shorter one and a very short part of it is there in the medulla for this. Later on we will see that the loop of Henle has got the function of concentrating the urine. So if you remember this now, what can be the function of the juxtamedullary nephron? Juxtamedullary nephron, they are specialized in concentrating the urine. That means they will excrete the urine with less amount of the water in it. Normally, in the human beings, 80% of the nephrons are the cortical nephrons and 20% are the juxtamedullary nephrons. But in camel, those who require to conserve much more amount of the water, so in that case, 75 to 80% of the nephrons will be juxtamedullary nephrons and 20% only will be the cortical nephrons. Now next, going to the renal blood flow. As you can see that, if you remember the anatomy, the renal arteries which are the direct branches of the descending aorta. What is the advantage of the direct branch? That means the renal arteries will be supplied by the blood which is having quite high pressure. This renal artery will divide into interlobular arteries. So renal artery will divide into interlobar arteries which will pass between the lobes. These interlobar arteries, now they will form an arc. So these are called as arcuate arteries. Now this arcuate arteries will enter inside the lobe now. So therefore they will be called as interlobular arteries. So next that will be their interlobular arteries. And from interlobular arteries, what we have is the afferent arteriole, which I have told about, which is going to form the glomerulus. So again, I will just repeat. This is the renal arteries. From the renal artery, what we have got is the interlobar artery. Interlobar artery will form an arc again. So this will be called as arcuate artery. From the arcuate artery, we have got is the interlobular artery. From the interlobular artery, we have got is the afferent arteriole. Now from the afferent arteriole, glomerular capillaries. So afferent arteriole will divide into capillaries. They will be called as glomerular capillaries. Normally what happens in the other parts of the body? Capillaries will unite to form venule and vein. But here the renal system is a portal system. That means it will have two sets of capillaries. So that afferent arteriole will divide into capillaries, and these capillaries will unite again to form an arteriole, which will be called as efferent arteriole. Now this efferent arteriole will again form capillaries, which will be called as peritubular capillaries. Those will be mainly surrounding the loop of Henle. So now we have got two sets of capillaries, glomerular capillaries and the peritubular capillaries. These peritubular capillaries will combine to form venules and the veins. And the veins will follow again the same path, and ultimately the renal vein that will be formed. Right? So as you can see in this slide, what are this? Renal artery, which is directly branch of the descending aorta. Then we have got is the interlobar arteries, arcuate arteries, interlobular arteries, afferent arteriole, and we have got is the glomerular capillaries, one set of capillaries, which will combine to form efferent artery and the peritubular capillaries, capillaries around the loop of Henle. Then venules, interlobular vein, arcuate vein, interlobar vein, and the renal vein. What are the peculiarities of the renal blood flow? The renal blood flow is very high. It receives about 22% of the cardiac output. So if you take it around 25% roughly, then imagine that within 4 minutes complete blood can go to the kidney, renal system and again come back. Why the kidneys require such high blood flow? Because the kidneys will have to maintain the homeostasis. So therefore the filtration, then continuous excretion of the metabolic waste product, that should be maintained. So that's why to maintain that filtration and GFR, high blood flow is required. Because of this high blood flow, the capillaries, glomerular capillaries pressure is very high. What happens at the glomerulus? The filtration. And ultimately it will go into the Bowman space. So to maintain that high filtration, the pressure in the glomerular capillaries should be very high, which is equal to 60 mm of Hg. But because of this filtration now, whatever the blood passing through the efferent arteriole, the hydrostatic pressure in that it will decrease. And the efferent arteriole will divide into peritubular capillaries. So what will happen to the hydrostatic pressure at the peritubular capillaries? It will be less. And if it is less, the absorption is being facilitated. So what is the next peculiarity of the renal blood flow? High pressure at the glomerular capillaries, but at the same time low pressure in the peritubular capillaries, which is equal to 13 mm of Hg, which favors the absorption. Similarly, more blood flow in the cortex, which is where the glomerulus is there, so that the filtration can be formed. But at the same time, we will see that to maintain and to generate medullary gradient, the medulla requires very less blood flow. So very less blood flow is there in the medulla. So that is another peculiarity of the renal blood flow. Next, filtration. Generally, the glomerular filtrate will be one which is similar to that of the plasma except plasma protein. And what maintains this high filtration? Fenestrae in the glomerular capillaries. Fenestrae means what? Large openings that will be there. So that will maintain this large filtration. As I already explained, there are two sets of capillaries. That means the renal blood circulation is a portal blood flow. Next, countercurrent blood flow. Now what do you mean by countercurrent blood flow? This peritubular capillaries, as you can see that, they will descend and again they will ascend along with the loop of Henle. That means the capillary will descend as well as it will ascend, lying parallel to each other, near to each other, but opposite in direction. This is called as countercurrent mechanism. We will see that this is important to generate the medullary gradient, right? And the next important peculiarity of the renal blood flow is autoregulation. In spite of some changes, even if the blood pressure, systemic blood pressure has changed, fluctuating, the renal blood flow that can be maintained, so therefore the GFR that can be maintained. So that is called as autoregulation. So these are some of the peculiarities of the renal blood flow. Now, in very short, we will see what is the basic principle for the urine formation. For that, I will just give you a good example. That if you want to, a messy cupboard, if you want to arrange it very nicely, there are the two ways which we can do it. What are the things which are not required? We can just take it out and put it in the dustbin. Other way of cleaning the cupboard is that take out all the things and whatever the necessary things, put them back. And what are the rest of the garbage that can be put into the dustbin? The second mechanism is one which is done by the kidney. What it will do? A large amount of filtrate is being formed at the glomerulus. And now, whatever the things, when the filtrate is passing through the PCT, DCT, loop of Henle, whatever the things that is required by the bodies, they are being again absorbed and put it back into the blood. There are some advantages of this, so that large amount of the filtrate, repeated amount, the blood can be filtered and again it can be purified, we can say, and the kidneys will be able to maintain the electrolytes balance exactly according to the need of the body. Once the filtrate is being formed, number of hormones will act over the nephron and they will tell exactly to the nephron that how many electrolytes, how much electrolytes that has to be absorbed, how much H plus that has to be secreted. So this is again precisely being regulated by the nephron, right? So what happens at the glomerulus is called as filtration. Glomerular capillaries, they are fenestrated and they have got the large hydrostatic pressure. So in the Bowman space or the Bowman's capsule, large amount of the filtrate will be formed. This is called as filtration. Whenever the filtrate is passing through the PCT, then the loop of Henle and the DCT, reabsorption is taking place. All this DCT, PCT, that is, they are tubular, these are lined by the cells. And these cells will have number of channels. So these channels will cause absorption of the electrolytes, they will cause absorption of the fluids. So this is called as reabsorption. And again, these substances will be put back into the blood, in the peritubular capillaries, which are being present. So there is reabsorption. So whatever the things which are not reabsorbed, they are excreted by the nephron and the kidney. Not only that, but these tubular cells, they have got the capacity to secrete some of the substances into this filtrate. That means they will take some of the substances from the peritubular blood and they will put it into the filtrate. This is called as secretion. So some substances such as metabolic waste products mainly, they are more secreted. They are not only filtered, they are not absorbed, but they are secreted. H plus ions, they are also being secreted. So, as you can see in this equation now, if a net substance in the urine, it is equal to amount of the substance filtered minus amount of the substance reabsorbed plus amount of the substance that is secreted. Right? So, this equation will give the net substance of the urine, that is V. With this basic principle now, the rest of the things we will see it in the next lecture.